Hey everybody, welcome back to the ECG channel. My name is Reed, and don't forget that you can download the PDF of this ECG down in the description below and follow along. And feel free to subscribe to the channel if you enjoy these videos. This is a fun one, so good cardiac physiology on display on this ECG. So first thing we're going to do is we're going to look at the forest, and the trees of the forest are my QRS complexes. And so say I come down to maybe lead to my rhythm strip. I see I've got these narrow complex beats, and then I've got these kind of bizarre early wide complex beats, and then I've got a couple of narrow one seams and then another wide, right? And so we get this alternating narrow, wide throughout the rest of the rhythm almost, right? Where we have narrow, wide, right? And so in the wide beats, notice they come early, so there's some premature beats coming in. We need to kind of work through what are they. And why are they interrupting this rhythm, and what are they doing while they, kind of disturb the rhythm? And so let's look at our normal beats. I see that they've got the normal beats have P waves in front of them. So we've got some P waves in front of our narrow complex beats. That tells me that these beats are probably normal beats that are just coming from the sinus node. We'll confirm this through the atria being captured by the AV node and sent through our nice His-Purkinje fibers through the ventricles to cause rapid ventricular depolarization. We can evaluate for that, right? If we look at our P wave morphology, it is upright in lead 1, and it is upright in AVF. So these, in fact, are sinus P waves. And you can even look, if you want, to look at the sinus rate. Sinus rate, if you look between the two sinus beats that are right here, the sinus rate would be something like 300, 150, 100. This will be 75, so maybe sinus rate of 85 beats per minute or so, which is all kind of in line with how I would expect a sinus node to function. And so we've got this sinus rhythm. Let's keep evaluating the sinus rhythm portion. Well, then we'll check out this kind of these premature beats, figure out what's going on. So let's take a look at what my AV node is doing. Well, I see that my PR interval here, if I look, my PR is in between 120 and 200 milliseconds, so that's normal. And it seems like every P wave conducts to a QRS complex whenever there is a P wave, okay? And so I don't see any P waves without QRSs. This means that my AV node, when called upon, is doing its job. Let's evaluate the morphology of the QRS. My QRS is narrow when it is conducted from these nice P waves. That's means that my QRS is less than 120 milliseconds, or 3 small boxes. My QRS complex is upright in lead 1. And if you look really closely in AVF, it's also upright in AVF. Right, here's another one, upright in AVF. It tells me that my QRS axis is going down and to the left, which is normal. And you can see I've also got good normal R wave progression throughout the precordium. As these R waves grow nice and tall in my lateral leads. I bet V2 was a little bit displaced, right? It seems like it grew a little early, a little fast. And so QRS looks good. My QT interval, if we look here, you can see this QT interval, that T wave seems to end before the midway point of my R to R, so that's reassuring. And if I look for any ST or T wave abnormalities, pathological Q waves amongst my normal sinus beats, I don't see anything that really sticks out to me. So now that we've kind of done that and evaluated, we've got this pretty normal sinus type rhythm, but it's just being interrupted by these early beats. Well, what's going on? So we've got these early beats. They are wide, complex. If we look, right, the width of the QRS complex in these early beats is wide. And so if we have a premature, it's bad handwriting. If we have a premature wide beat, we're thinking it's either a premature ventricular contraction or a premature atrial contraction with aberrancy, right? Ashman phenomenon, aberrancy. And so I like to look in front of my QRS complex and see, are there any P waves that I notice on the preceding kind of QT interval and in ST segments? I don't see any there, right? And so V1's a really good place to look because usually you can see some little sharp atrial activities that can kind of help you determine if there's anything kind of atrial ectopic going on. And you can see, as I scan through, I don't really see any, right? Scan through all these premature beats, I don't see any. And so I would say that these are likely premature ventricular contractions. And if you look really, really closely on this PVC, so here's our PVC. So this is the premature ventricular contraction. That's the PVC. And if you look really closely on the ST segment, you can see just that little notch. And that little notch is a retrograde P wave, right? So we know that it's possible that if we have a PVC that, say, comes from right here in the ventricles, it fires off, it depolarizes, it's a wide complex rhythm as it's going through gap junction to gap junction within the ventricular myocardium, creating that wide complex QRS. Some people's AV node is actually able to retrograde, send that signal and cause retrograde P waves through the atria. So we're actually seeing that. You can see it best right here in lead 3. Right, look at that nice notch. You can see it here in lead 2, nice notching at the end of that. And so those are negative notches in my inferior leads, and so that even gives me more data that, yeah, my inferior leads, if they were going to capture a P wave going away from them, it would be negative, right? And so that's what we see. So likely what's happening is we're getting these retrograde P waves, and when they go retrograde, well, they're going to also retrograde and kind of override the sinus node. And it's going to cause something called, see this long pause before my sinus node picks back up? Sometimes you can call that a compensatory pause. So compensatory pauses are essentially when you're just waiting for the SA node to fire back up. And so I can almost guarantee you that that is what we're seeing throughout this rhythm. And so we get frequent premature ventricular contractions, right? Here's another one, another one, another one. It's happening in a bigeminal pattern briefly, right? Bigiminy means that it's happening every other beat, right? So we briefly have a run of ventricular bigiminy right here. And then we see our sinus node gets a couple beats out, right? So let's put this all together, and what do we get? We have a sinus rhythm. Sinus node rate seems to be at about 85 beats per minute. We have normal sinus conduction through the AV node and the QRS, but we have frequent premature ventricular contractions with retrograde atrial activation and a compensatory pause. So I hope this helps. I hope this video helps you better understand kind of a little bit more of that cardiac physiology. Remember, not everybody can create retrograde P waves. Not everybody's AV node has the circuitry to conduct retrograde. And so not every PVC has to necessarily have retrograde atrial activation for you to call it that. So I hope this video helps. If you have any questions, put them down in the comments. And if not, thank you so much for watching, and we'll see you on the next ECG video. Take care.